Hello, everyone, and welcome to Retina Connect, a program of events dedicated to sharing and discussing practical surgical experience. My name is Monica Jogovic, and I am from the Marketing Director at Dutch Ophthalmic. And thank you for joining us this evening. This night's webinar's topic is trauma of the eye. You are currently muted. If you would like to communicate with the moderators, you are welcome to ask any questions that you may have through the chat. You can watch additional videos of our Retina Connect series on our YouTube page, and this video will also be loaded there at some point as well for you to refer back to. Without further ado, I'd like to introduce tonight's presenters. We have Gaurav Shah from the Retina Institute in Missouri, Dean Elliott from Massachusetts Eye and Ear, Adrienne Scott from Wilmer Eye Institute in Maryland, and Mark Kwong from Associated Retina Consultants in Arizona. All presenters this evening are paid consultants of Dutch Ophthalmic USA.
Monica, thank you for the effort and time that Dutch has put into this. And most importantly, thank you to my colleagues and friends, Dr. Elliott, Dr. Scott, and Dr. Kwong. And appreciate to all of the folks joining out there on a Thursday night. So hopefully we'll make it exciting and fun for everybody. So we want to get going. So Mark's going to present the first case, and I'm going to advance the slides for Mark. Remove metallic intraocular foreign body. Go ahead, Mark.
So this is a young lady. I mean, essentially, she is an ER nurse. 3 days prior to presentation, she had decided to be a good idea to slam two hammers together while putting up a cabinet system, probably from something like an IKEA cabinet. She knows she had left eye discomfort. It caused some blurred vision. Initially, she was seen by the ER or urgent care, sent to optometry, diagnosed as a corneal abrasion, and presented to us after there was no improvement. Initially on presentation to us, her vision was 20/20 in the right eye, 20/25 in the left eye, pressures of 16 and 14. Next slide, please. So these are her pictures on presentation. If you notice, I mean, that left eye is not terribly impressive. By the limbus, there's that vertical linear line of subconch heme, and that's all she had in terms of initial presentation. And I mean, sort of understands that if there was no dilated exam done, well, you would just call that maybe an abrasion. When it didn't get better, she actually went to the ER, and they finally convinced her to get a CT scan. So next slide, please. And at that point, the ER doc was reminded why any sort of possible intraocular foreign body requires a CT scan. As you can see in all three slices, there is a definitely discrete hyperreflective foreign body within her eye.
Right here. So Mark, before you get to what you did, the CT scan shows a time step of 10:24 p.m., right?
Yes.
So it's 10:24 p.m. in Phoenix on a Saturday night, okay? What is sort of your thought process in terms of when you looked at her timing, or when did you do this? It's 10:24 p.m., you get this in the ER.
So we actually did it the afternoon of the next day. So, I mean, traditional teaching, as you guys know, was to take these as quickly as possible. One of the good things to actually come out of some of the Gulf Wars and then later Afghanistan is there was an immense body considering the trauma and the topic of intraocular foreign body trauma work. And in general, what most of it showed was that if there's no signs of active infection, you have, I mean, some of the studies on soldiers, due to other injuries, they delayed upwards of a month before treatment.
So Dean, if it's 10:24 in Phoenix, it's going to be 1:24 in Boston and Baltimore. So Adrienne and Dean, what if it's 1:24? What do you guys do at 1:24 a.m. besides figuring out that why am I on call? Maybe we'll go Adrienne first and then Dean.
Yeah, I agree completely with Mark. If it doesn't seem like there's active infection there, and this is the kind of case we would take the next day, or when the next kind of the A team came in, where you could call in people kind of the next OR day, you could get them in. If this was a Saturday night, we would do it that Sunday morning, and just the next day.
Dean? Dean, you're muted.
There we go, sorry. Same thing, we would do it the next day. There's another argument as well that you don't have your primary team in the middle of the night, including anesthesia, and things are safer when they go during regular work hours. So next day.
Okay. So while
Well,
you're
actually,
go
well,
ahead,
one
Mark.
thing. So one difference is I'm in private practice, and in Phoenix and Arizona in general, probably 99% of all of our surgeries are done in outpatient surgical centers. The only ones that are done in hospitals are at the children's hospitals. So if this actually came in at like 1 a.m. on a Saturday night, I'd have to wait till Monday, just because none of the trauma centers are really set up for retina. And it's generally, as Dean and Adrienne were alluding to, it's safer to have a team that knows what they're doing than having to split your attention between your patient and making sure your scrub tech doesn't unplug the machine.
So Mark, exactly what I was going to bring. There are a lot of cities where you cannot do retina work or, eye surgery on the weekends. So let's say in Boston, in any city, Baltimore, Phoenix, obviously staffing is an issue at many places, right? That's a problem. So how do you, while you're waiting, do you give any antibiotics, Avalox? Do you give oral? What are your thoughts on that?
Well, let me just add one thing. The military studies, those are high velocity projectiles after an explosion. Those are pretty much sterile. This may not be, so you got to be a little careful here. That's why I would do this, the next morning, next day, I think is fine. But you do have to be a little careful in the civilian setting. It is a little bit different than military. And plus, this is not an organic foreign body or anything like that, where those I would do pretty quickly.
So Dean, you would give antibiotics, oral antibiotics while waiting?
We admit all open globes and give them IV antibiotics. So we have an advantage. I have a huge hospital that I work at, and we can have inpatients. So yes, we would give intravenous antibiotics upon admission and do the case the next day, but they would have already received a dose of antibiotics before the surgery. We wouldn't give intravitreal. Sometimes people have done that if they're worried and they have to wait till the next day. They give an injection of intravitreal antibiotics. We don't do that.
Okay. So I think for, if you're in private practice and you can't admit them, Avalox is a great choice because the concentration of oral Avalox, we did a study on this many years ago, is 50% of plasma in an uninflamed eye. So it's a really great drug and we keep it in the offices for endophthalmitis. Before you do endophthalmitis surgery, delay Avalox, well, one dose of Avalox. So I think admission, Avalox, all these things are important. Mark, can I go to what you did here and go to the next slide?
Certainly. No, I'm also a big fan of Avalox.
Let's go to the next slide. What did you see there, Mark?
So these were the fundus photos that we took of her on presentation. And you can see that she does have some pigmentary modeling, implying commotio, and the picture on the right-hand side of the screen is infratemporal, and it's pretty hard to miss what that is. And you can see that it's been there already long enough that there's developing a inflammatory fibrinoid reaction around it.
Yeah. And Mark, you thought this was just edema out here?
Yes.
Not fluid, but just edema.
Correct.
Okay. And so when you look at this, as far as, is there, we all want to do things by small gauge and, 27 gauge and the smallest gauge possible. When you look at this, Mark, when you looked at her, what sort of, what's your typical gauge and what did you decide to do for her? I know we're going to show the video, but what kind of went through your mind?
Well, I pretty much use 27 gauge for everything, which it's a fair thing to argue whether or not that is a wise choice. I know that for any sort of intraocular and foreign body, I'm going to have to make a large hole, but I'd rather make one large hole than 3 large holes.
Okay. So you started this case and you're going to show us, but your plan was 27 gauge and then whatever instruments that you want to use to get it, you're going to make that a larger hole. Is that correct?
Correct.
Okay. Adrienne, followed by Dean. What are your thoughts on gauges and stages?
Yeah, so I typically do these types of cases 23 gauge. I feel like I just have the greatest armamentarium of tools at the ready for me. I'm not quite sure what this, how much of a challenge getting this foreign body is going to present. So I'm going to go with 23 gauge and potentially even be ready to enlarge the wound of the 23 gauge trocar sclerotomy just as needed to get the foreign body out.
Okay, Dean?
Yeah, I do these 23 gauge and, probably gonna have to remove the cannula and open up the sclerotomy with an MVR blade or something.
Okay. So now we've got this patient. Mark's already seen them. You get for surgery. Mark, what about anesthesia? What kind of anesthesia? You put patients like this asleep? Or if anesthesia says, you know what, Dr. Kwong, we're ASC, we don't want to do general. Can you just block this woman?
Actually, so we did her under local with a
Okay.
peribulbar block. In
Okay.
general, unless it's just a gaping open globe, we'll still do the majority of those under local anesthesia. So we have the anesthesiologist bedside in case they need to add a little something during the case, but generally the approach is not much different than if this was just a pucker.
Okay. So I think that's kind of some of the classical teaching, right? You have to do these, or people always thought you need to do them general. And I agree with you. I think every case is different and you have to take that in mind. Adrienne and Dean, any comments? Again, there's no right or wrong answers. It's everybody's what they're comfortable with.
I was curious, what mark do we think that little pigmentary changes of the fovea? Do we think that is related to the trauma somehow?
I do, but that's only just because in hindsight, I've seen her post-op and they were largely resolved.
Interesting.
Regarding anesthesia, we do these under general. We get a little worried about doing a retro or peribulbar block in an open globe in case there's a hemorrhage or something.
So, and so Dean, you're right. And also one of the things when you work with residents and fellows, right? It's also a little bit, cases sometimes take longer and there's more teaching and so on and so forth. So I think there's different circumstances every institution. Mark, anything different in terms of consenting these patients? When you do an informed consent, did you add anything extra?
I usually remind them that with trauma, that even though presentation of vision is the best prognostic factor for final vision, that all bets are off and that some patients are going to require multiple surgeries and the vision may fluctuate. And at the end of the day, it may not improve.
Okay.
So I tend to be more doom and gloom and let them know that there's not going to be any quick fix. Okay.
And Dean and Adrienne, anything different or about the same?
I agree, spot on. Just making sure that they know that it needs to require multiple surgeries. In this particular patient, if I'm worried about something going on in her fovea, I might be extra careful about kind of promising what her vision outcome will be, because I don't know if that little spot is going to damage her central vision. But pretty much the same as Mark.
And I pretty much tell them we're going to save the eye. That's it. Just save the eye anatomically. I'm not sure what you're going to see, but that's what I start at. So aim very low. All right, so here's the video, Mark. You can describe what you did.
So here I'm using the 27 gauge high flow system. I pre-place a peritomy because I know I'm going to have to make a big hole. I don't think I show it on this, but yeah, so this is just flipping off the cannula. The newer trocars make it much easier. Here I'm doing the PVD. If you notice, as I'm pulling up, it's not clear in the video, but the foreign body actually comes up on the hyaloid. I make a circumferential incision rather than an axial. One of the key things you'll find, so I'm using forceps rather than a magnet or a basket or anything. Part of that is because it's private practice. And in the outpatient surgical centers, you're very limited about what you can use. Same reason why I'm doing 27, because that's what they have in the packs. This is your common issue and headache with intraocular and foreign bodies. You get it, it's beautiful, it's coming up, and your hole's not big enough. So it falls back in. Here I've cleaned off most of the fibrin so I can get a better approach. As I'm using these forceps, if you notice, I'm teasing it upwards. I'm not dragging it across. This time with the bigger hole, it comes out fairly easily. Then I sew it up. Here, I do some laser. Now, this is just a standard laser. Right here, it's harder to see, but down on the temporal side of the screen, I was actually using the illuminated guard for the light pipe, so I could do external laser. Because again, that little linear streak that is that is a supratemporal in this case. Well, maybe I'm upside down. Anyway, the linear streak where the entry wound was is so anterior, it's in the pars plana. So to be able to visualize that for laser, it's actually easier to have illuminated scleral depression. So unfortunately, she did great. And within 1 month, she was 20/25. I did do intravitreal injections at the end of the case. I don't know whether it's really necessary, but I'm a big fan of voodoo.
What about Adrienne and Dean? Maybe Dean first, and then Adrienne. Dean, what about in a case like this? As Mark was saying, he was at an ASC, so sometimes obviously you're limited to what you have. But what about the use of chandeliers for something as a case like this to do bimanual? And then Adrienne, if you can comment on the use of maybe PFO, that is, if this drops back or you potentially can decrease this drag, because I have done it myself, right? We all make errors or sometimes mistakes, and that sometimes even though you think you're not dragging, there's always gonna be a little divot or edema or sometimes even a tear. So Dean first on chandeliers and Adrienne on the use of PFO.
So depending on the size and shape and orientation of the foreign body, sometimes you can grab it easily with one hand and a light in the other and remove it. And other times, you can assess that it's going to be difficult and you might need two hands to rotate it a little bit or tilt it up so you can grab it safely without impaling the retina. And in the latter case, I would put in a chandelier. Most of the time you don't need one, but in some of those cases, I think it helps. And then the key is, as Mark said, make the sclerotomy opening wide enough. And if you have a good grip on it, it should be able to come out. I also turn the infusion up pretty high when I'm about to pull it out. It helps kind of push it out a little bit. But otherwise, a similar way of doing it.
Adrienne?
Yeah, so I think PFO is a great idea, and I have used it in cases. So, for example, lensectomy in a very dense lens, as you mentioned, Gaurav, the lens falling back on the retina can be certainly traumatic. I wouldn't have kind of reached for it in this particular case, but I don't think it would have been a bad idea. I tend to avoid PFO if I can, just because of the expense of it. But I think it's a great idea in certain scenarios.
So Mark, that's a great outcome. And I saw that you were able to leave her phakic, which is great. And she's done well. And you said you did not give any antibiotics, intravitreals?
No, I gave her Cephinvanc.
Cephinvanc, okay.
Yeah. So one thing that we didn't mention that can be considered, and I find that it doesn't work well, but sometimes what you can do is use the soft tip. And actually the smaller gauge soft tip sometimes works better than a larger 23 gauge soft tip, just because of the surface pressure that you can develop with the vacuum. But you bring that up, and if you don't have a chandelier and stuff, when you bring it up interior enough, you're able to see it directly just through the scope illumination, removing biome or whatever secondary viewing device you do. You pull out your light pipe, and then you can do a handover technique into forceps to allow you to sort of pass it off and bring it up. The biggest concern about that, especially if you're not using Viscoat or PFO, is if you drop it, that's right on the linear sight path, and you're likely to bounce it off the fovea, if not just the macula.
Okay. All right. Well, a great case, Mark. And I just want to echo your points. I think that lighted depressor that you can put on the light pipe is great. I use it all the time, just so I can, operate by myself without somebody depressing for you. So it works really well. It comes standard with the kit. We did a video of this in 2008 for the ASRS that won the Film Festival Award. So it's been there for a long time. Okay, so one case in 20 minutes. So this is good. Less slides, the better. So now we're going to move on to Let's see, Dr. Scott, Baltimore. Let's see what you have a fun case first. Go ahead, Adrienne.
Sure. So thanks, Gaurav. There was a really horrible windstorm that hit the East Coast a couple of years back. And so there was a 28-year-old police officer who was out in the field, and he got hit in the eye with a shard of plexiglass. He had a penetrating open globe injury, limbal scleral laceration with uveal prolapse, eyelid, and canalicular laceration. And he was brought to our local level 1 trauma center and then referred to our retina clinic for further evaluation after the open globe repair.
Okay.
Okay. So this is his retina and all that we saw. So he was aphakic. His lens had been exposed with the injury. So this was the B scan that we saw, and there was no view to the fundus, obviously. And so this B scan was significant for significant vitreous hemorrhage. The retina, we couldn't quite tell what was going on, but we thought there was almost like a closed funnel configuration here. So we had a lengthy discussion with the gentleman about do we go in, do we operate, what's the, potentially, is there any vision that may come back? And he was motivated and wanted to proceed with surgery.
So Adrienne, before we go to the video, as far as imaging, right? People, it's easy to get a CT and all these things, but it's not that easy to judge ultrasounds on these kind of injuries. So 2 questions. One is, how do you do an ultrasound on an eye that you suspect has a rupture? And number 2, how do you get good at seeing what you're seeing? Because it's a lot of echoes that are, you don't know what material is what. So maybe educate us a little bit about that. And then, Mark and Dean, please chime in, because I just think ultrasound is very difficult to interpret in these eyes.
Yeah, so when I saw him, he was a couple of weeks past his initial open globe repair. So, theoretically his eye had been closed. So the ultrasound we thought was, safe in that scenario. And I'm very spoiled by being at a large academic center with a dedicated professional echographer who, gives you the readout of what they think it could be. And they're pretty accurate and spot on most of the time. But certainly I've done these myself, and in an open globe primary presentation, I wouldn't put pressure on the globe if I thought there was a risk of expulsing tissue if the globe were still open.
Okay. And Dean and Mark, any comments on your ultrasonography skills in a post-ruptured globe repair? Because I tell you, I've done these before and I just can't tell what is what tissue. Dean?
Yeah, I agree. We don't do it on the open globe. We usually do it post-op day 1 after the primary repair. We have experienced ultrasonographers as well, and sometimes they make a great call that there's retina incarcerated in a wound, and sometimes we're all wrong. We look at it and think one thing, and we get to the OR and it's totally different. So yeah, it is very difficult, as you noted.
Okay, Mark, anything to add?
I just think this is a fantastic picture. A lot of times it's the way I approach it is, I know what it's supposed to look like. Whatever looks like it's not where it's supposed to be, then I presume it's bad. It's not technical. It's not very impressive. It's borderline picture pages approach, but really, it's how often does it correlate with what you see when you're inside? It's going to be a mess.
Yeah. All right, Adrienne, let me go to the video here, and if you can describe what you did.
Absolutely. So I have to give credit for now my partner here on faculty, Dr. Alvin Liu, and I did this case together, and he was kind of put this video together. So you can see how the globe was repaired. You can see the extensive corneal scleral laceration, eyes already aphakic. So this is a closed funnel RD, and you can see here we're kind of externally depressing and with trying to get a start. So there's some membranes anteriorly. We're trying to carefully dissect using Bimanual Technique through the cannulas. We do put in a chandelier light because we're doing some bimanual dissection. We switched to the light pipe, the big clot of heme and subretinal membranes that we're just working away, trying to hope for landmarks to become visible to us. So we say, okay, remove blood. Blood is bad. Okay, keep going. And then we start to see something looks kind of familiar. So that's the retina. So again, now we went back to Bimanual Technique. And this is a trick I really like. I saw at a conference once that one of the last meetings about kind of putting Helon into the funnel to try to stabilize it while you do your dissection. Okay, so we do a little bit more anterior dissection and then put in perfluorocarbon, and we start to see landmarks or something that we recognize. So that was very reassuring to see the actual retina optic nerve. And of note, you can see how the vasculature is completely kind of tilted downward. So we went back, did some more anterior membrane dissection. And he flattened. We put PFO in all the way to cover the retinal edge, and we were happy to get the take up of the laser, and did a fluid air exchange, removed our perfluorocarbon, and we left him under silicone oil. Sutured all the wounds. So always suture your wounds. I always suture my wounds in these open globe cases, even if it was small gauge, I would always suture. Air bubble anterior.
So Adrienne, a beautiful technique, beautiful example in a really awful situation for this patient. So you had a patient who had a ruptured globe repair. Do you typically wait a couple of weeks until you sort of do surgery on these patients? Is that kind of your approach?
Yeah, I'd like to, if at all possible, for a couple of reasons. One is I think you can get a better idea of the overall prognosis of the eye once things settle down. Particularly, a lot of these cases will have bad corneal edema, maybe from the first surgery. And for a case like this, you want the media to be as clear as possible, particularly the cornea. So if you can let the cornea clear, the pressure's controlled, the eye's stable, the person's not in pain, I think it's very reasonable to give it a couple of weeks once things have stabilized and the globe is closed.
And I noticed when you started, you put an AC maintainer, right? When you are, that's what it looked like. I always find in these cases, the hardest part a lot of times is just where's infusion, right? What space is infusion is? Is it underneath the retina? Is it in the choroidal space? Where is infusion? So I always kind of find infusion management to be the most challenging, important part of the case, because if that doesn't go well, it's a myriad of issues. And I'd like to get Dean and Mark's comments on how do they handle some infusion issues, when you can't see the infusion or trouble seeing. So we'll go with Mark first and then Dean.
So, a lot of times, especially with 27 gauge, I'll just stick the trocar through the limbus into the anterior chamber. If it's, if the globe's too soft and I'm getting too much resistance, then I'll actually just attach the infusion line to a short 30 gauge or 27, 25 gauge needle and just carefully bend it and tape it so it's not poking into anything I don't want it to. But yeah, once you get the eye pressurized, then you have a much better chance of entering space you want to, rather than finding out you've created more problems.
Dean?
If you have a pretty good view and it's a trauma case, I like the 6mm infusion and I put it in the normal place. But if you don't have a view, you can't confirm that it's in the vitreous cavity, then I do the anterior chamber maintainer. And most of the cases require that because they have hyphema or dense vitreous hemorrhage. And like you said, you can turn a case that's salvageable into a disaster if your infusion is in the wrong place. So it's critical that you get it in the AC and you can visualize the tip and you could raise the pressure and clean out the blood and then subsequently put it in the normal position once you have a nice view.
Now, Adrienne, here the lens was gone, but sometimes I've done this before. If I see a frank cataract, I just stick the infusion into the lens, right? I'm going to take the lens anyway, but that's a way to make sure if they already have a cataract and I have to take the lens anyway, I just stick the infusion right into the lens. I know I can see it and I'm assured it's in the eye. But let's go back to your case. So you got the infusion in and you put in, so tell us a little bit about viscoelastic, and was it a sandwich of viscoelastic and PFO, or what did you do there?
Just started with the viscoelastic to try to open the funnel, and these cases are daunting. And from that ultrasound, we didn't really know what we were dealing with. And like you said, first thing you have to go back to your principles and just try to pressurize the eye. Try and see if you can see landmarks. And sequentially, trying to dissect. There's a lot of anterior membrane dissection to even open the funnel. And then once we saw that we could open the funnel, and we did a little bit more dissection, but then the viscoelastic is a very good, almost like a third hand sometimes in this case, to be able to stabilize the funnel while we kept doing our dissection.
Okay. And one thing that you didn't seem to have a problem that I've had issues before is in these cases, if they're aphakic and you've got an infusion going to the eye, sometimes you'll get leakage through their corneal incisions or whatever other incisions they've had to repair the ruptured globe. I know Dean is shaking his head, but they say everything looks great, and then you go inside the eye, and now you've got it looks like a sponge. Everything is leaking and you've gone through 4 bottles. So that is another thing to keep in mind. So when you did the PFO, what was there some thought that I could get subretinal PFO, or, how did you sort of overcome that sort of fear or perceived fear?
Yeah, great question. So we typically, when we put in PFO, we do lower the infusion pressure so you don't have all these, stray bubbles of PFO kind of flying everywhere with a high infusion pressure, and you just go very slowly. This wasn't a retinal tear; it was a 360 tear. The whole retina was a tear. So, you typically just go very slowly and take it slow and try to make sure you don't get. I just filled the eye up full of PFO, allowed us to do our laser, and then it worked well with fluid air exchange.
Dean and Mark, you have anything else to comment, or just exactly what Adrienne said?
Well, I mean, go ahead, Dean.
Yep.
I just want to emphasize, she said the word slow twice, and that's very important, because if you do it fast, sometimes the retina tilts over and it gets into the subretinal space. And if you do it slow, you get less rotation, even though you still might get rotation. So I think that was important, what she said. I hope everybody heard that.
Yeah, that's critical. And this was Adrienne, you did this 23 gauge. So you got to the PFO, you got the retina flat. We could tell obviously it was rotated because, of where it was incarcerated, because that was the point of its sort of, where it was stuck. So in these cases, we know this from the translocation cases where I typically do a PFO oil exchange. I feel pretty comfortable doing that, just to decrease any sort of, the retina sort of redetaching and, more of an issue. You did a beautiful job just going to air. So what were some of the tricks, and you can tell people how you avoided doing a PFO oil exchange? And maybe I'll have Mark and Dean go in terms of, did they do that or they just go to air?
Yeah, I absolutely could have done a direct PFO to silicone oil exchange. Absolutely. Just didn't consider it in this case. We went through the step of air, and you have to treat it like you would a giant tear. It is a huge, 360 tear. So you have to go very, the word slow, carefully, methodically, drying the edges as you go and remove the perfluorocarbon slowly. So as air comes in, you go back, you dry each edge with the soft tip cannula, and just take your time with it, just like you would with a giant retinal tear, to prevent the retina from slipping.
Dean first, and then Mark, any comments on either PFO oil, or you guys just go to air and then put oil in?
I go to air and then put oil in.
Okay. Mark?
In general, I'd have to try to repair this just with the viscoelastic without the PFO, which makes it a whole nother nightmare. But yes, when given the option, I'm not a big fan of PFO oil exchange, since we don't use much PFO. Got it.
Yeah, I don't use much PFO, but when I do it in cases giant tears, I just do a PFO oil exchange. So one thing, Adrienne, that you, again, a lot of times you did all these things because you know what you're doing. But before the oil goes in, it's very, very important in trauma cases to make sure, recheck the cannula, or whatever cannula you're going to put the oil in, because these eyes or cannulas tend to rotate and tilt. And the last thing you want to do is get suprachoroidal oil. I've seen it and dealt with it. It's kind of a nightmare. So be very careful, at least that I found for people listening, that, before you start putting stuff in a trauma case in the eye, double, triple, quadruple check the cannula has not moved, because it is easy. These cases are longer. The cannula sometimes ends up being perpendicular, moves, and simple things like that will, as Dean will say, will turn your worst nightmare into your second worst nightmare and third worst nightmare that comes over and over again.
So, Gaurav, we have a couple of questions to the panelists. If you click on the chat, we can maybe answer some of those. We have, what are the advantages of PFO to oil? That helps prevent slippage. So sometimes in these 360 GRTs, if you leave a lot of peripheral retina and you go to air, sometimes it slips, just like typical giant tear would slip. If you go PFO to oil, you're less likely to get the slippage.
And typically the way I do it is D.O.R.C makes a high viscosity if I'm going to do this case 23 gauge, they have a 23 gauge cannula that you can put the oil through the infusion. It's got to make sure a high viscosity cannula. And then, you just use the other 2 ports for your, light, and then with passive extrusion. If you don't have that, you can put 2 chandeliers in and then do it where, the 2 ports, then you can put the oil in one and then extrude to the other one. So you gotta either have a chandelier to do it or do it through the infusion cannula. Those are the only 2 ways, at least, that I think are most reasonable.
Typically, well, actually, one question for you guys. Are you guys using 1,000 or 5,000?
I typically use 1,000, but Dean and Adrienne?
Typically 1,000.
Yeah.
Yeah, we used to use 1,000 and where I trained, and then where I work, we only used 5,000. I tried to get 1,000 to catch on, but it didn't really. I was like the only one using it, so we do 5,000.
Well, hopefully, maybe we can get something in between, right? So, all right.
Yeah, well, one thing, so when we're putting in oil, at least the way I do it, since usually with 27 gauge, I find using 5,000 through those cannulas is like watching paint pill.
Yeah.
We'll actually, I just manually inject it from the syringe using an angiocath, and it's a great use to help building the strength of our fellows.
Yeah, yeah, good arm strength. So Adrienne, I know you have more. You have one more slide. So here we go. We wanted to describe and see what some issues are here.
Yeah, so we're so happy that he's attached, the retina stayed attached. So, and this is him about 1 month post-op under oil. And you see, as we saw at the end of surgery, this torsion of where the fovea is kind of tilted, everything's tilted downward. And he actually has some torsional diplopia. And, the case, I wasn't even expecting him to have an acuity, let alone have acuity enough to be diplopic. So, interested to panelist colleagues here, how would they manage this case? And then, let you know what we did.
Mark first and then Dean.
So, first thing I'd want to have, I don't know, so I'm sure you did a long discussion as to the expectations of the patient. So, sometimes the best option is to consider further blurring the eye, either with glasses or a contact lens. The idea of taking this magnificent repair, redetaching the retina in hopes that I can slide it back into place better and stick it back down and have it stay, I think that's pretty optimistic.
Dean, you want to poke the bear or no?
No. So I think Adrienne pointed out that if you put the perfluorocarbon in and do it slowly, someone else asked the chat as well, how do you prevent the retina from tilting over? So do it slowly, and if the peripheral retina is stuck together, sometimes the anterior portion of the retina is stuck because of clots, you can do more of a peripheral retinectomy and get less retina remaining, a smaller postage stamp that's less likely to make it tilt. It's also less likely to have torsion like you have here. But you can resolve some of the torsion on your own. If you have about a clock hour, usually with time, your brain compensates. And we know this from back in the day when people were doing macular translocation. If you have 2 clock hours, which this is probably, some people can compensate and many can't. So sometimes people do muscle surgery for this, or kind of what Mark said, just leave the eye alone and block it out so the patient doesn't have too much interference with the bad eye. You have a few options, but it's pretty rare that we do muscle surgery on this. That's not at all common. Most of the time we just leave it and block out the eye, but many times it's amazing. The patient gets less torsion. You ask them every time they come in and they say it's a clock hour, then it's 3/4 of a clock hour, then a half a clock hour. And after 6 months, the torsion's gone sometimes.
So Adrienne, he has oil in the eye right now. Is a plan permanent oil here, or are you ever going to take it out?
Well, actually, we did end up removing the oil, and the retina remained attached, and he still had the torsion, but he's stable just with an aphakic contact lens. And to Dean's point, he's thrilled. He's not complaining. I think the diplopia became less of an issue, and he is he's functioning okay. He's happy. Like we were able to save the eyes. and we talked about at the beginning of the surgery, we're just trying to save your eye, you know. So, you know, at this point, we didn't want to do any further surgery and poke there, as we said. I mean, if you were going to fix this, as colleagues have noted, you'd have to, you know, redetach the retina. Sometimes you can do it with just only a subretinal injection, and you can kind of see if you can inject subretinally. Maybe you can detach the retina and somehow allow it to you know, straighten out the torsion. But this eye had been through so much, I was not in favor of doing additional surgery, and he's compensated well.
Yeah, this is a tremendous outcome from what you started. And this is where human beings are great at adapting. Like all of us adapt to different situations. And I think that you just say, thank you, you've got a spare tire, and hope the other eye stays okay, and then move on. But yeah, tremendous work, Adrienne, and thank you for the beautiful video and the discussion. So, okay.
This case is an excellent example of the old surgical adage that the enemy of good is better.
Yes, yes.
Yeah, and keep in mind, if you tried to redetach this and twist it back to its normal shape, I mean, it's probably not going to happen. I mean, it went this way for a reason. The retina was contracted and it rotated, and you know, what's to say that if you did it again, it would land in the right place? It probably wouldn't.
Yeah, no, I think at 2,300, you know, they should be ecstatic. Adrienne, you worry about patients always ask you, or they ask obviously this whole sympathetic ophthalmia, you know, like what are your thoughts on that? We'll go with Adrienne first, then Dean, and then Mark, in that order.
Yeah, that's a very, very good question. And, you know, theoretically, he would have been at risk for this and always would be lifetime. That's a very, very good question. Unfortunately, we've not run into that with this particular eye, but it's a good consideration. It should be part of the informed consent process.
Dean, and then Mark.
It is extremely rare, and it's treatable these days. So I don't think it's a big deal. It's so rare.
Yep. I've seen one case in 23 years, right? But that case ended up doing poorly. So you remember that one. Mark?
No, I mean, I agree. Cross that bridge if you must. Let them know it's a possibility. But I mean, I think this is as close to a perfect outcome as is possible.
Yeah, it's great. Great.
I remember, you know, when we had the macular translocations, like under PFO, we used to take the 2 Tano scrapers and kind of try to maneuver the retina around and kind of, you know, erase some of the torsion. But I was, again, not wanting to poke the bear here. Somebody also asked in the chat how long to leave the oil in. I took it out after about 3 months, actually.
Okay.
So, thanks.
All right, we'll go to the next one. Dr. Elliott.
So this is a 79-year-old gentleman who fell down and had a globe rupture, 17 millimeters, quite large, zone 3. He underwent primary repair. Keep in mind, he was no light perception before the primary repair, no light perception after the primary repair. Then the patient was sent to us. He was still no light perception. And you see he has a crystalline lens in place, but you see some very unusual things going on behind the lens, which we figured out was his pars plana and aura and peripheral retina, as you see here, with a massive hemorrhagic choroidal. Go to the next slide, please. So on the left, you see this massive hemorrhagic choroidal, and we told him to come back in a week where we would reassess. Came back in a week, and you see on the right, the choroidal is now liquefied. He still has a massive choroidal, and he's still no light perception. But the important thing about this case is sometimes no light perception eyes can do well if the cause is a very large choroidal hemorrhage. So we operated on this patient shortly after the right-sided ultrasound was taken. So the ultrasound on the right was taken about a week after the injury. We operated at, you know, I think day 8, day 9. And let's see what we have. Go to the next slide.
So Dean, before we go to your video, I just kind of want to get your thoughts. So you see this ultrasound with the fellows, and kind of what goes through your mind when you kind of prepare yourself? Like, what are some of the things, infusion issues? How are you going to manage some of these things? And then number 2, did this patient have a reverse APD, or do you look for that, or like, what sort of do you do anything special? Because I'm sure you had a plan.
We do look for APD. The patient had a very small APD, actually, not a 4+ APD by any means. In addition, we figured out where the choroidal was and where we should drain it, with the help of the ultrasonographers. We figured we would use an anterior chamber infusion and remove the patient's lens, since everything was pushed up against his lens, even though his lens was relatively clear. I mean, he was 79 years old, so it wasn't crystal clear. But that was our approach: anterior chamber maintainer, drain the choroidal, and then remove the lens, and hopefully things will fall back and we'll be able to put the infusion in the proper place.
And I think that's the point, Dean, I want to make is when we look at these patients, right, you have to have a plan. What are you going to do? What instruments you're going to need to have, and have all that processes either in play before you certainly see the patient, and make sure your OR staff knows this is not going to be a quick case. I'm going to need a whole bunch of instruments, and I might ask for stuff I haven't even thought about. And I think that, as Dean has eloquently said, all of this kind of went through his head, so it should go through anybody's head as they see a patient like this. Okay.
And somebody asked, what did we give him for the choroidal hemorrhage? We didn't give him anything. He wasn't in any pain. If they have pain, then I might give him steroids or something, but he had no pain, so we did nothing. We just let it lyse. We figured it would lyse in a week, and here we are a week later. It looks like it's not clotted anymore, so.
Okay, we will get to the show. Here we go, Dean.
So we are cauterizing the sclera, where we intend to drain the choroid. We put the anterior chamber infusion in, and you'll see the choroidal blood comes out, pretty massive amount of blood. And here we're doing a lensectomy, and now we've already put the infusion in the normal place. And here you can see a 360 giant tear with retina incarcerated in the wound. So we're removing subretinal membranes, which took a long time. And now we're cutting the cutting the retina free from the incarceration site. And then after much picking on the inside, moving scar tissue, we put perfluorocarbon in, did it real slowly, made our retinectomy a little further posteriorly, flattened them out, gave them laser. You can see it looks pretty darn good. What's amazing about this case, which I'll show you in a minute, we obviously put in oil,
So you showed oil going in. You just did a air to PFO air and then oil. Is that what you did here?
Correct.
Okay. And then no chandeliers. I didn't see a chandelier here.
No chandelier.
Okay. Old school. That's awesome. This is what we want. And then did you suture your where you drain the choroid?
I did not suture the choroidal drainage site. I did suture the sclerotomies.
Okay, yeah, that's kind of what it looks like. And what was your reasoning not to suture that? Thought you might get more drainage?
Yep, I think sometimes a little bit of blood remaining in there and it oozes out during the post-op period. No particular reason to suture it. I think I've never sutured one in my life, and really hasn't been a problem as far as I know.
Okay, yep. Same here. The only thing I would mention is I always tell the fellows that be very careful if you're going to put peribulbar anesthesia around the eye, that if you have either a buccal drain site that's not sutured or something, just be careful, because as things can go out, things can come in.
So go to the next slide. And so you can see the intraoperative view. You can see at the end of the surgery, it's flat. I think you have one more slide.
Yep.
And then post-op, you could see a week later. What's amazing about this case is the patient ended up 2060, pinhole 2050. And that is obviously extraordinarily uncommon. Most of these do not end up that way. But I'm showing it for a few reasons. Number one, it illustrates nicely the incarceration, the choroidal hemorrhage, and the approach. But this case, remember, it didn't have blood under the retina, right? I was able to see the retina through the crystalline lens, and the choroidal was right there. All the blood was in the suprachoroidal space, and we learned that blood is toxic, but it's toxic to the photoreceptors, and no blood was ever really in contact with the photoreceptors in this case. So I think the reason this particular patient had an incredible outcome was twofold. One, no blood touching the photoreceptors, causing toxicity. And, we did the surgery about 7, 8, 9 days after the injury. So with timely surgery and some lucky anatomy with respect to where the blood was, he did well. We published this as, a remarkable visual recovery. I mean, I've never had another one that did this well. I mean, clearly they all don't do this well, but we're showing it just because it gives you some idea of what a no light perception eye could potentially see. I mean, it's just so hard to believe.
So I think that's an important point, that most of these cases, unfortunately, are in young people, right? They're between 20 and 30, or, in the prime of their life, in terms for, they've got another 60, 70 years in front of them. So I think an NLP in a 16-year-old, you got to be careful to say it's unoperable. Okay. I just think that you certainly don't want to do surgery that's totally without any merit. But I do think, as Dean has clearly shown here, that not all NLP is NLP, right, Dean? Would that be fair to say?
Yes, you also need some good luck. So he didn't get PVR. He did get a pucker, and we went back in when we removed the oil, we removed the pucker, and he still stayed 20/50. It was a pretty minor pucker, but right, I mean, you have some good luck, right? Some people 10 out of 10 PVR, and some people get, almost no PVR, like this guy.
Yeah, you can take a retinal detachment in one break who looks great, and then 6 weeks later they come with a horrendous PVR. So Dean and Mark and Adrienne, we haven't talked about this topic, but maybe this is a good case for this. As before we go to the next case, what's your, Dean, indication, and then we'll go to Adrienne and Mark, for putting a buckle on in trauma cases? I know this case, again, it is very different, but let's just say a trauma case where it's not a funnel detachment like Adrienne and Dean showed, but what is there an indication, and when? Dean?
I think actually most open globes would benefit from a buckle. I don't do it if there's a choroidal hemorrhage, and I don't do it if there's a 360-degree giant tear, or I think there might be, or there's retina incarcerated in the wound, and I think I might have to do a 360 retinectomy. But if none of those things exist, a buckle, in my opinion, actually helps. I mean, we did look at this, and we published a big review on post-open globes, and one of the risk factors for developing recurrent RD due to PVR was the absence of a buckle. So I think it's nice to have one. It's very difficult to put on, as you know, after an open globe, especially if it's a big open globe with where the muscles were just isolated, a week or two prior to do the primary repair. There's sutures back there. The conj is scarred to the sclera. It's difficult, but I think it helps.
Adrienne, and then Mark.
Yeah, I like a buckle. Agree with all of Dean's points, particularly if the laceration involves the vitreous base. I like a buckle to decrease, to support the vitreous base. If there's just a posterior lac, maybe something small, or something involving the limbus, not necessarily, but if it involves the vitreous base, I like a buckle.
And typically, Mark, if you were to put one on, do you do a band or a tie, or what do you have a choice?
I would still use a 4170 on this. I find that an encircling buckle in a case like this almost acts like the flamingo ring that we used to use when we did full thickness PKs.
Yep. I'm a believer in buckles for many things, but yeah, absolutely. Okay, so onwards and upwards. Dean?
Yeah, let me make one comment. My fellow Marissa Tiger, who used to be chief resident here at Mass Anterior and is a trauma expert, has texted me that 19% from a series from Mass Anterior that were no light perception ended up seeing something reasonable, and 20 to 30% of those that were no light perception got some vision back, and 17% were better than 2,500. I didn't even realize it was that good. That's pretty darn good.
Yeah, it's a third, right? 1/3. Okay, Dean, take it away.
So this is a young gentleman who had a long nail go into his eye. You can see the primary repair that was done. Then the patient was referred to us. Next slide. And you can see, at least the way our ultrasonographers interpreted this, that there was a low-lying retinal detachment and retinal incarceration in the exit site. Seems reasonable to interpret it that way. Next slide. So what this patient had, you can see the exit site here, the perforation site, which is arrowed. There's a hole in the retina, and the wall of the globe has now scarred because this is 2 weeks later. And what this patient had was a large subretinal hemorrhage throughout more than just the macula, out to the mid periphery. And luckily, the hemorrhage was not clotted. And we put in a perfluorocarbon bubble and rolled it around multiple times to express the lysed blood out the retinal break. And we did this over and over and over. And go to the next slide. And eventually, almost all the blood came out. So you can see the exit site nicely lasered, and you could see some residual blood. And if you go to the next slide, you'll see where the blood was. This circle is where the whole thing was just covered in subretinal blood, very thick. And, you know, a nice little technique just to roll it around. And eventually you can put the perfluorocarbon in, put a big bubble, and a bunch comes out the hole, then take it out. Then the blood accumulates at the macula again due to gravity. You put another bubble in and it expresses it peripherally, and you roll it around a little, and you do that over and over and over. We probably did that 6-7 times. We basically removed almost all of the blood. Pretty hard to believe. I was not expecting that. I was also worried that the blood might be clotted, but it wasn't. So once again, you know, luck was on our side. I'm showing the cases where we've had some good luck, not showing you the ones with the bad luck. Okay, next. And you can see a year later, I mean, the site looks great. The macula looks pretty darn good. And one more slide here, you can see he's aphakic and he's got a corneal scar, but with a contact lens, he's 20/30. You know, a nice result from something that should have been a total disaster.
Well, it's like real estate, Dean. Location, 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 and luck. Adrienne.
Well, I was just going to ask Dean that, well, this is a great case. And he came with his own drainage retinotomy, right? He came with it, right? So it's kind of neat. If he had not had that, I guess, would you have made your own drainage retinotomy if he just had this diffuse subretinal hemorrhage?
You know, knowing what I know now and that these things can do quite well, and the blood is probably lysed and not clotted, I would have done a drainage retinotomy and done it the same way.
Yeah, Matt, that's a great outcome. Mark, any comments?
I think it's brilliant. It also goes to the old adage of God protects drunks and fools. This guy was very lucky.
All right. Well, I have a couple of real quick cases. It's 8:56, so we want to try to get done on time. So this was a cataract case that the cataract doctor sent to us. He started doing cataract surgery. You can see that there's been some human trauma that's been done to this eye. And he just stopped and was sent to us saying they got scared after they started looking at the lens. The lens was moving too much. But you can see there's iris. You can see this iris issues. There's all kinds of issues. So this was human trauma that caused this. And you know, this is something, again, taking the lens, putting it back, but this had never happened to me. So this is kind of a foreign body case, but we put the 23 gauge fragmentome, and as we're fragging, this is a pretty thick lens. It's very hard. And I tell the fellow to stop for a second when this happened. The frag broke, right? I've never had that happen. Half of the frag broke in the eye. It looked like a sword. And so sometimes things like trauma cases unexpectedly occur. And I think you just have to take a step back, figure out what's going on. And here I took the frag out, but we knew it was going to be big enough. So we just made it with the MVR blade, but it can happen. So anything's possible, as they say. And last case I want to show is this case. This is, as I was telling the folks beforehand, this is from almost 20 years ago, before we had all these wonderful instrumentation. And this was an intraocular foreign body that hopefully this was converted from a VHS tape. So it will hopefully, it'll take a little while, but it might play. There we go. You know, no, we didn't have great light pipes. You can see it's dim, bad recording. So this is a big piece of metal. Then we took the intraocular magnet, and this was all probably should be 19 gauge. I have no idea. It was 20 gauge surgery, but we're kind of looking at it, you can see this is the previous wound that was repaired, and these are big forceps. And somebody had mentioned the hole is never big enough, right? And you can see the eyes getting soft because of fluidics. You got to be careful. So now we're kind of passing, no chandeliers at that time. And now we're passing, and you can see how the eye softens, right? So we're afraid of a choroidal hemorrhage, bad things occurring. But eventually, this is kind of an odd piece metal, right? It's fairly big, okay? And it always appears bigger when you bring it up. So now it gets stuck, right? So Dr. Baker Hubbard was the fellow at that time with me, and Baker did a fine job. I told him to make the hole bigger, but didn't listen to me. So I said, okay, Baker, you got to make sure it doesn't fall back. And then here's the magnet. I don't know what he was trying to do there. I guess just hold it in place. And then Baker picks up a 0.12. And I said, I think you need something better than a 0.12. So I said, take the biggest conch forceps we have because it's in the wound. And a lot of times it doesn't fall, but luckily Baker's did not fall, did a fine job, and you can see. But it goes to the adage, you got to make the wounds bigger than you think it is. And, again, these are sclerotomy sites. There was no valves. We had to suture our cannulas. And, we all remember these days where the eye would deflate and inflate because the fluidics just weren't as good. So I wanted to end with an oldie but a goodie of how far we've come in this sort of surgery, because these guys showed you beautiful videos that are perfectly focused, bright, illuminated with all kinds of tools. But it shows you that it's not the tools that make us, it's our techniques, right? So we can still do these cases. And, if you don't have, your favorite machine, or you don't have this or don't have that, I just think you got to just suck it up and, do with the best you can. But you can still plan with whatever you have. So before we leave, I'd like to each one of you give words of wisdom in a trauma case. We will start with Adrienne first.
Sure. So biggest thing, have the best informed consent of your life with the patient. Set expectations that this is a multi-step process, probably a multi-surgery process, and document everything about your discussion, and really just give some time to thinking through the plan and what you need and what you might think you need, and just be ready for what the eye gives you and have thought through what you're going to do.
Dean, and then Mark.
Well, I'd say two things. Manage expectations, like Adrienne said, that is absolutely critical. You'll have a happy patient if you tell them that the injury usually results in blindness and you're just trying to save the eye. They'll be very happy if they see anything. And the other thing is what you alluded to earlier, plan your surgery very carefully and think of all the things that can go wrong and what you're going to do if that happens.
Mark?
So as you guys know, I'm a big fan of country colloquialisms and fake wisdom. This is what I teach all of our fellows, and it's more from the surgical standpoint than from the patient perception standpoint. One, in trauma, you go from known to unknown. So when it's all, you can't tell anything, you still know where the limbus is. Two, all bleeding eventually stops. And we can either take the Kenny Rogers approach of know when to hold them, when know to fold them, or the more educated one of the enemy of good is better. So keep it simple.
Yeah, I think those are all words of wisdom. They're great words that I'm writing down because I need to follow these. My only word to add to those great words is that in trauma patients, spend the time with them at the initial visit and every visit, because this is very traumatic for people. They were fine, an 18-year-old or 20-year-old or 30-year-old who could be our family member, who could be anybody, was fine until an hour ago. And now you're telling me we're lucky to keep the eye, right? So it's very traumatic. You need to spend the time and explain to them exactly what all the three panelists have mentioned. But this just can't be a 5-minute PVD check, right? This is going to take some time and effort and energy. And I think it behooves us as physicians to put ourselves in their shoes if we were the patient going through this. So I think it's really, really important to sort of have that route. And this is not a time to save time, right? You can do something else, but you got to really figure this out with the patient. So I know it's 9:03, so we took 2 extra minutes or 3 extra minutes, but we got started at 8:01. So we should be on time. Monica, thank you again. And do you need to end this any other way?
Yeah, I just want to thank all of you for a wonderful presentation, and I think it was a really great discussion tonight. And thank you everyone for attending, and have a great evening.
Okay, thank you so much. And thank you to all my 3 friends and panelists, and Monica and D.O.R.C.
Thank you. Pleasure.
Thank you.
Thanks.